Arthroscopic double row suture anchor repair of an acute posterior bony Bankart lesion, as performed by Dr. Eric Kropf at Temple University Sports Medicine. The authors report no significant conflict of interest related to the creation of this video. We present the case of a 17-year-old high school football player with recurrent left shoulder instability. No significant past medical or surgical history is noted. Imaging confirms a minimally displaced posterior glenoid fracture with an associated periosteal avulsion and a small intra-articular loose body. Diagnostic arthroscopy is first performed on this left shoulder in the lateral decubitus position. The pathology is confirmed, and the posterior bony Bankart lesion is next mobilized with the use of a periosteal elevator via this posterior working portal. Once the fragment is freely mobilized, a motorized burr is brought in through the same posterior approach and used to freshen up both the native glenoid and the osseous fragment. This will stimulate bleeding and subsequent healing of the bony Bankart. A medial row anchor is now placed at the most medial extent of the native glenoid. The suture is now shuttled with a conventional suture shuttle device, but not tied at this time. Two anchors are placed independently, one at the distal extent of the bony Bankart lesion and one proximally. These anchors are not around the osseous fragment, but at the most proximal and distal extent to provide for rotational control of the osseous fragment. These are tied via conventional technique. A lateral row anchor is now drilled at the lateral articular cartilage margin. The previously passed suture is now retrieved and placed through the eyelet of a knotless anchor. That knotless anchor is now brought in and provisionally seated just off the articular margin of the posterior glenoid. The suture limbs are tightened to confirm an excellent reduction of the posterior bony Bankart as well as the associated labrum. That anchor is then seated to its final location, and when tension is confirmed, the suture limbs are cut. A final inspection of the shoulder confirms that the humeral head is well centered. There is no evidence of posterior subluxation or instability, and the native labrum assumes a normal configuration. The posterior working portal is now closed with a single plication stitch. Here you can see a monofilament passed first distally and then retrieved proximally and ultimately tied at an extracapsular location. This will provide a small degree of added stability to this posteriorly unstable shoulder.